One of the biggest groups that we treat with AML are patients who are older than age 60, 65, and also those patients who are unfit for intensive chemotherapy. Many times this is the same group, what we call older and unfit. But as more and more we recognize that many older patients are not necessarily unfit, and many unfit are not necessarily older. So I think that we need to really define these categories separately. But the bottom line is that there are a group of patients, a majority of them, which may not be good candidates for intensive chemotherapy because of the underlying comorbidities, organ dysfunction that precludes them from receiving this therapy, the higher rates of toxicity that occur in these patients. And so our approach has been to use lower intensity therapy in these patients to preserve safety and tolerability, which in the past has also affected efficacy and long-term overall survival. I think with the introduction of new agents, after understanding the biology of AML, agents such as Venetoclax, a BCL2 inhibitor, IDH1 and 2 inhibitors, as well as FLT3 inhibitors, we've now been able to augment the efficacy of this lower intensity therapy to match what we used to be able to do with intensive chemotherapy approaches. So now you have a new paradigm, a new calculus, where you're using lower intensity therapy, still preserving that safety and efficacy, but delivering the non-toxic therapy that we want to deliver. As I mentioned, the primary approach these days has been the combination of low-intensity therapy, such as hypomethylating agents, or low-dose cytarabine in combination with Venetoclax. In the front line, this has led to CR/CRi rates in the range of 60 to 70%, and an improvement in overall survival up to 14.8 months with the combination of HMA plus Venetoclax. So really a revolution in lower-intensity therapy for older patients. The next question is, what is the next step? And certainly that's a question on all our minds. How do we further improve this? Well, again, we want to maintain safety and tolerability, but we want to be smart about it. We want to say, how do we improve efficacy further? I think two potential ways are to add on top of the backbone of an HMA plus Venetoclax, and that's been done in many clinical trials, where a third agent is added, like a targeted molecule such as FLT3 inhibitor or IDH inhibitor, on top of the HMA Venetoclax backbone in specific subsets. Immune therapies have been added, such as antibodies such as sabatolimab, magrolimab, to the aza-ven backbone in certain subsets. ADCs such as gemtuzumab, ozogomycin have been added to Venetoclax to augment activity, potentially in higher risk or in certain subsets of AML. So these are the ways that you can implement the strategy there. Another way is to change the backbone. So I mentioned that Venetoclax increased the activity of HMAs as well as low-dose Ara-C. We have investigated a combination backbone of cladribine and low-dose cytarabine, which remains a low-intensity, non-anthracycline-based approach, and the combination of Venetoclax yielded complete remission and CRi rates of about 90%, with 80 to 85% rates of MRD negativity. So very high rates of response with excellent early tolerability and low early mortality. So these are some of the approaches that we're taking in older patients or unfit patients treating with lower intensity therapy.